Let's talk about a different type of peripheral neuropathy through this case. Here we have a 45-year-old woman who presents to the emergency department with right facial droop. She reported waking up and starting her day, but when she drank coffee, it ran out of the right corner of her mouth. She also reported mild right retroauricular pain starting the day before. On exam, she's afebrile, no nuchal rigidity, normal mentation. Cranial nerves actually show a prominent right lower facial droop, subtle delay in eye blink and weakness of the right eye closure, and mildly diminished forehead wrinkling on the right. There's no dysarthria, motor weakness, sensory loss, or ataxia otherwise. So, what is the most appropriate next step in this case based on what we think is happening? Do we get an MRI of the brain with and without contrast? Do we get labs like ESR-CRP? Or do we just treat with prednisone alone or valcyclovir alone? I'll give you a few seconds to lock in your answers. And the answer is treat with prednisone, because what is this? This is Bell's palsy. Exactly. This is the unilateral peripheral facial nerve palsy, or cranial nerve 7 palsy. It's a peripheral nerve disease. So getting an MRI is not necessarily needed, right? That's for central etiologies. ESR-CRP are nonspecific. So, unilateral peripheral facial palsy, or Bell's palsy, is usually idiopathic, but can have a viral prodrome, usually have an acute onset over hours or the course of a day. And accompanying symptoms are really important clues. This is going to help us localize. In addition to facial weakness, you can have periauricular mastoid region pain, hyperacusis, and altered taste. Important to not get confused with your patient who may say, I've got paresthesias or altered sensorium of my face as well. And what do we know about the sensation of the face? It's not supplied by the facial nerve, that's motor, right? What is the sensory supply of the face? The trigeminal nerve. So you have to test for sensory function in these patients and ensure it's not just that feeling of heavy, something's going on, and actually a sensory deficit, because that would then localize to the trigeminal nerve. Now, treatment. Data supports monotherapy with steroids or prednisone alone with a burst and taper for about 5 to 7 days. Antivirals or therapy is usually just an adjuvant therapy to the prednisone, so we don't utilize it as monotherapy alone. All right, now this image is really important because it helps us differentiate between what upper motor neuron facial weakness looks like versus lower motor neuron. Is the facial droop because of a Bell's palsy or cranial nerve 7 lower motor neuron peripheral disease? Or is it because of a cortical problem like a brain stroke? So let's look at this first image. What we can see is that there is different supply for the top of the face versus the bottom, the forehead, upper face versus the lower face. So we know the contralateral cortex supplies the lower aspect of the contralateral face. And we actually have dual supply from bilateral cortices to the upper part of the face or the forehead. So if I have an upper motor neuron lesion in that cortex right there where you can see it cutting off, I will still have ipsilateral supply to the top of the forehead. So you will have contralateral lower facial droop with forehead sparing in a cortical lesion. Now, looking at the second image, if you get rid of and just cut the nerve altogether, you cut that lower motor neuron lesion, you cause a cranial nerve 7 palsy, any input coming from the brain, whether it's contralateral or ipsilateral, is gone, which is why you have both upper face and lower face involvement or forehead involvement in a lower motor neuron type lesion.